Here's our roadmap for the explainer. We're starting with lymphatic anatomy. Then we'll move into hygromas and acute infections, before tackling the real heavy hitter, lymphedema. We'll break down classifications, diagnostic tools, and wrap up with medical and surgical management. All right, let's dive right into this. Starting with the basics of lymphatic anatomy and tracing the flow. Developing at just 6 weeks gestation, this system really has one crucial job, returning protein-rich fluid back to the systemic circulation. And it pulls this off via lymphangions. These are basically contractile structures that pump fluid upward, fighting right against gravity using Starling's law.
Now, tracing that fluid upwards brings us to a massive clinical and surgical correlate, Troisier's sign. So, the lower limb and abdominal lymphatics drain via the cisterna chyli right into the thoracic duct. And here's the kicker. The thoracic duct opens exactly at the confluence of the left internal jugular vein and the left subclavian vein. Because of this super direct plumbing route, abdominal or gastrointestinal cancers can spread straight up the thoracic duct. They'll literally manifest right there as an enlarged left supraclavicular lymph node. You might know it as a Virchow's node. It is an absolutely classic, vital sign of advanced disease.
Moving on to hygromas and acute lymphangitis, dealing with sequestered tissues and infections. When anatomy derails early on, sequestered tissue can form a cystic hygroma. But if properly formed ducts faces sudden acute bacterial assault, think strap or staph, you get acute lymphangitis. And that's marked by extreme pain, fever, and a really distinct reddish streak tracking up the skin.
And this brilliantly illustrates a key physical exam concept, distinguishing compressibility from reducibility. Compressibility is what you typically see with vascular or fluid swellings, like a hygroma. When you press it, it empties, but the second you let go, it spontaneously fills right back up. No counter-pressure needed. Reducibility, on the other hand, which is exactly what we see in hernias, means the swelling goes away when pressed, but it actually requires the patient to physically cough or strain to make it reappear.
Okay, so here's what you absolutely must know about cystic hygromas. Because they form in the posterior triangle of the neck and are filled with clear fluid, they transilluminate beautifully. Interestingly enough, they can actually be detected on an in utero ultrasound, acting as a soft indicator for chromosomal abnormalities like Down syndrome. But here is the major warning. Surgical excision carries a huge risk. If you injure the superficial spinal accessory nerve during the procedure, your patient is going to suffer permanent shoulder dysfunction, so handle with extreme care.
Let's shift our focus to Brunner's classification and the staging of lymphedema. Lymphedema happens when the system just completely fails to clear interstitial fluid. This triggers an insidious, creeping cascade of inflammatory cytokines and, eventually, severe fibrosis. To really grasp how this disease progresses, we use Brunner's classification. It kicks off at the subclinical phase. Here, you've got excess fluid and histological changes happening under the surface, but you can't actually see the swelling yet. Then we hit grade 1, pitting edema. Now, this is your crucial window of opportunity, because the swelling still disappears with limb elevation and bed rest. If we miss this window, the tissue fibrosis and we cross over into grade 2, which is non-pitting edema. Finally, it progresses to grade 3, bringing chronic, severe, and irreversible skin changes. The entire goal of medical management: intervene before that grade 3 stage locks in for good.
So the crucial point here is that lymphedema is fundamentally a clinical diagnosis. You've got to know exactly what buzzwords to look for on a physical exam. You'll see Stemmer's sign. That's the inability to pinch the fibrosed skin on the dorsum or the top of the foot. You'll also spot what's called a buffalo hump, where the natural hollow contour of the ankle is completely swallowed up by swelling. And finally, squaring of the toes. This happens because the limb size is increasing from all that fluid, but the physical space inside the patient's shoe, well, that stays the same, literally forcing the toes into a cramped, square shape.
All right, moving into primary versus secondary lymphedema, where we look at defective pathways versus external blockages. We basically have to categorize the disease origins to treat it effectively. Was the system built defectively, or was it destroyed from the outside?
Let's break that down. Primary means the production of fluid is totally normal, but the actual lymphatic ducts or valves have a structural defect. The most common primary type is lymphedema praecox, which predominantly strikes females right around puberty, along with congenital forms like Milroy's disease. Secondary lymphedema, though, that is far more common overall. This is when an external factor wrecks the drainage. Globally, and especially when we're talking about the lower limbs, the absolute #1 cause is filariasis, a parasitic infection you get from a mosquito bite. But for the upper limbs, the most common cause is actually post-mastectomy lymphedema. This happens when axillary lymph nodes are surgically removed or irradiated during breast cancer treatment. Next up, diagnoses and complications, visualizing the damage. Now, to quantify the actual volume of swelling, water plethysmography is your gold standard. But to pinpoint the exact location of an obstruction, direct lymphography with indocyanine green is the absolute go-to.
Now, what's really interesting about this is how a single axial CT slice through the mid-calf can be such an incredibly powerful diagnostic tool. If a patient comes in with a swollen leg, this CT instantly differentiates the cause. If it's venous edema, you're going to see increased volume inside the muscular compartment. If it's lipedema, you'll see a symmetrical increase in subcutaneous fat that usually spares the feet. But if it's lymphedema, the scan reveals a very specific, coarse, reticular honeycomb pattern right there in the enlarged subcutaneous compartment. It's a dead giveaway.
Now we have to address a very grave complication. If lymphedema is left unmanaged for years, the patient is at serious risk for Stewart-Treves syndrome. This is the aggressive development of a highly malignant angiosarcoma as a direct result of chronic lymphedema, something we particularly see in post-mastectomy patients. Clinically, it presents as these bluish or reddish nodules popping up over the swollen skin. The management requires incredibly aggressive surgery and chemotherapy, but tragically, it carries a really poor prognosis.
If you take just one number away regarding Stewart-Treves syndrome, absolutely make it this one, 8 to 10. This aggressive cancer doesn't just develop in a few months. No, it requires a significant lag time of 8 to 10 years of chronic, long-standing lymphedema before that angiosarcoma develops. This is a classic, defining timeline for this specific pathology and definitely one to remember.
Let's move into our final section, medical and surgical management, focusing on reversing the swelling. How do we tackle this? Well, management relies heavily on a multidisciplinary approach, meticulous skin care, strictly avoiding blood pressure cuffs on affected arms, and utilizing slow, safe, isotonic exercises, like swimming, to gently pump that fluid out. The absolute cornerstone of medical management is decongestive lymphedema therapy, or DLT, and this happens in two phases. Phase 1 is the intensive phase, done under expert supervision. It involves specialized manual lymphatic drainage and multi-layer bandaging to dramatically shrink the fluid volume and really soften up that fibrotic subcutaneous tissue. Then you have Phase 2. This is the lifelong maintenance phase, relying heavily on self-care, compression garments, and strict hygiene to keep the swelling at bay. And remember, initiating Phase 1 early is absolutely critical to prevent those permanent, irreversible skin changes we talked about in Brenner's Grade 3. Now, when you're applying those compression garments, the parameters are incredibly specific. You need the highest pressure, 100% right at the ankle, graduating down to 40% at the groin to effectively force that fluid upwards against gravity. These pressures are significantly higher than what you'd use for standard varicose veins. We're targeting 30 to 40 millimeters of mercury for the upper limb and a really heavy 40 to 60 millimeters of mercury for the lower limb. But listen, there is a massive safety check you have to do here. Before applying this kind of high pressure, you must verify that the patient's ankle brachial pressure index, or ABPI, is strictly greater than 0.8. Applying high-pressure bandages to a limb with poor arterial blood flow, that can quickly precipitate severe ischemia. So always check. So what happens if medical management fails, the swelling keeps increasing, or recurrent infections just keep plaguing the patient? That's when we turn to surgery. Resective surgeries aim to physically cut out the excess volume. You've got the Homan's procedure, which involves removing a wedge of skin and tissue, though it does carry a risk of skin necrosis. The Thompson procedure actually buries a deep epithelialized dermal flap inside the limb. Then there's the Sistrunk procedure, a straightforward wedge resection with primary closure, which is actually the most commonly performed resective option. However, modern medicine is rapidly shifting toward reconstructive procedures. Things like nebulate supramicrosurgery are gaining immense popularity because they physically anastomose tiny lymph nodes to veins to restore actual fluid flow, rather than just hacking away at tissue.
Now, out of all those resective options, you have to know that the Charles procedure yields the absolute worst cosmetic outcome. In this operation, the surgeon radically excises all the affected subcutaneous tissue entirely down to the fascia, and then covers that raw area with split-thickness skin grafts. So yeah, while it does strictly remove the bulk, it leaves the patient with an incredibly severe lifelong cosmetic disfigurement. It's an intense trade-off.
Which brings us to the incredible future of lymphatic management.
As reconstructive techniques gain massive popularity, surgeons in advanced centers are now using ICG dye to identify and anastomose tiny lymphatics directly to veins right in the middle of an initial breast cancer surgery. They are literally bypassing the drainage system before the lymphedema even has a chance to start. It begs a fascinating question. With this kind of super microsurgical prophylaxis allowing us to anastomose lymphatics to veins during surgery, are we rapidly entering an era where devastating secondary lymphedema becomes a completely preventable condition? It's an incredible thought and an amazing testament to surgical advancement. Thank you so much for joining me for this explainer.